What if the medication your doctor prescribed to help you with benzodiazepine withdrawal was actually prolonging your suffering? Recent evidence suggests amitriptyline's anticholinergic effects can interfere with the precise neuroplasticity your brain needs to recover from GABA downregulation. I'm Dr. Fergal Armstrong, and today we're navigating one of the trickiest decisions in addiction medicine, whether amitriptyline is safe during benzodiazepine-induced neurological dysfunction or bind. We'll examine the pharmacology, the risks, and what the evidence actually tells us about managing protracted withdrawal symptoms. First, let's clarify what we're dealing with. Bind affects an estimated 10 to 25% of long-term benzodiazepine users who discontinue their medication. This isn't your typical withdrawal that resolves in weeks. We're talking about symptoms that persist for months to years. Severe anxiety, cognitive fog, sensory hypersensitivity, muscle twitches, and sleep disturbances. The key difference? These symptoms follow a wave and window pattern, periods of improvement followed by temporary setbacks. Your GABA receptors have been downregulated by chronic benzodiazepine exposure. Think of it like this. If benzodiazepines are volume controls that have been cranked down for years, your brain needs time to naturally restore normal sensitivity. This process of neuroplastic recovery can take 6 to 24 months, sometimes longer. Now, why does amitriptyline come up in this context? It's a tricyclic antidepressant with strong sedating properties. For someone experiencing debilitating insomnia 8 months into recovery, the promise of sleep can feel like a lifeline. Amitriptyline works through multiple mechanisms. It blocks serotonin and norepinephrine reuptake. It has antihistamine effects, and here's the crucial part. It also has anticholinergic properties which can interact with GABA receptors. The sedation typically kicks in within 30 to 60 minutes of taking it. Patients often report their first full night's sleep in months. But here's where we need to pause and ask, are we helping recovery or are we interfering with it? Here's what concerns me about using amitriptyline during bind recovery. Your brain is actively trying to upregulate GABA receptor sensitivity. This is a delicate, time-dependent process that doesn't respond well to interference. Amitriptyline's interaction with GABA receptors can potentially slow this natural healing. Think of it like trying to reset a complex system while someone keeps adjusting the controls. Clinical observations suggest that patients who add psychoactive medications during early recovery often experience prolonged or intensified symptoms. Beyond the GABAergic concerns, amitriptyline brings its own risks. The anticholinergic effects can worsen cognitive symptoms that are already challenging in bind. We're talking about increased confusion, memory problems, and difficulty concentrating. There's also the issue of orthostatic hypotension, which is sudden blood pressure drops when standing. For somebody already dealing with balance issues from benzodiazepine withdrawal, this adds another layer of falls risk. Now let's talk about two serious safety concerns. Amitriptyline can cause cardiac arrhythmias and conduction delays, particularly in older adults. In patients already experiencing anxiety and panic symptoms from bind, cardiac side effects can be genuinely frightening and potentially dangerous. More concerning is the seizure threshold lowering effect. Benzodiazepine withdrawal, even months later, can leave patients with increased seizure susceptibility. Adding a medication that further lowers this threshold creates a compounding risk that we need to take seriously. I've seen cases where patients developed their first seizure months into recovery after starting tricyclic antidepressants. While correlation isn't causation, the mechanism makes biological and plausible sense. So what does work? The emerging evidence points towards non-pharmacological approaches during the acute recovery phase. Gradual exercise programs, despite initial symptom flares, consistently show benefit for neuroplastic recovery. Sleep hygiene remains fundamental. Consistent sleep-wake times, cool, dark environments, limiting screen exposure before bed. I know this sounds basic when you're experiencing severe insomnia, but these fundamentals support your brain's natural recovery processes. For patients who absolutely need sleep support, some specialists prefer shorter-acting options with less complex pharmacology. Low-dose melatonin, typically 0.5 to 3 milligrams, works with your natural circadian rhythms rather than against them. Magnesium supplementation, particularly magnesium glycinate at 200 to 400 milligrams before bed, can provide gentle muscle relaxation without GABAergic interference. Now, I'm not saying that amitriptyline is never appropriate, but the decision requires careful risk-benefit analysis. If a patient is experiencing severe neuropathic pain-like symptoms that are genuinely unbearable and non-pharmacological approaches have been exhausted, it might be considered. The key thing is timing and dosing. Generally, I would suggest waiting until at least 12 months post-discontinuation of benzodiazepines when the acute neuroplastic recovery phase has stabilized. If used, start with the lowest possible dose, sometimes as low as 10 milligrams, and monitor closely for cognitive worsening. Most importantly, set clear expectations about trial duration. This isn't a long-term solution. If significant improvement isn't seen within 4 to 6 weeks, or if symptoms worsen, discontinuation should be considered. The most important message I can share is this: bind recovery is typically a slow process that improves with time. The wave and window pattern means you'll have good days and difficult days. This doesn't indicate treatment failure or the need for medication. Focus on supporting your body's natural healing, adequate nutrition, gentle movement, stress reduction, and patience. I know that's challenging advice when you're months into difficult symptoms, but the evidence consistently shows that natural recovery produces the most sustainable outcomes. If you're working with a healthcare provider who isn't familiar with bind, seek out specialists with experience in benzodiazepine withdrawal. The standard psychiatric playbook often doesn't apply here, and well-meaning but uninformed treatment can sometimes prolong recovery. What's been your experience with sleep during benzodiazepine recovery? Have you tried amitriptyline or other sleep aids? Share your insights in the comments below. Your experience might help someone else navigate this difficult journey. If this information was helpful, subscribe to MedHeads for more evidence-based addiction medicine content. Remember, recovery from bind is possible, but it requires informed decision-making and patience with the process. Until next time, I'm Dr. Fergal Armstrong, reminding you that understanding the science empowers better choices.